So we're going to start with femur. Oh, I see it. Okay. Go ahead and lay down your hand. You're making me nervous with your head all. I'm gonna push your shoes over here. Okay, so we're gonna start with the femur. So with the femur, we're going to use a 14x17 cassette. It's going to be in the bucky lengthwise. Okay, so 17 top to bottom, because our femur is long, not wide. So we'll put that in there, close it. Maybe, where did it close? The last time you broke it. For real, where is? There. Okay, so 17 in there. Make sure you're in detent. So check your transfers. We're in detent. Come down to 40 at the cassette. And then we're going to open our light field to be 17 top to bottom on the 40-inch line. As far as side to side goes, it's just going to depend on your patient, okay? So for the proximal femur, the top of our image receptor goes at the ACES. So the ACES is going down here. We put the top of our light field there at the ACES. If you have it set at 17 top to bottom and you're lined up to your image receptor, then you know the top of your cassette is at the ACES, right? We put a right marker down here in the bottom corner. The reason for putting your marker in the bottom corner like this is because when you go to do the distal, you don't move your marker and you know that you have overlap of the bone, okay? So it'll be in the bottom of our proximal image, but it'll be in the top of our distal image. And then I'm gonna have you pigeon toe your feet. So pigeon toe the feet so that we get that femoral neck nice and parallel with the image receptor for the proximal version. For shielding, like I said, we'll use a lap shield and just put it here over her chest and abdomen, like so. So just make sure it's not in the light field down here, okay? So there's our proximal AP femur. For the distal, we're not gonna move our marker. We're gonna move down. Oops. We're gonna move our tube down. And you need to have the bottom of your image receptor 2 inches below the knee, okay? So I'm gonna collimate it down a little bit just because I don't wanna re-expose all of this, okay? So we'll close it down like that. Her knee's right here. I'm still 2 inches below my light field. And you're going to put your toes, your foot straight now. So for the distal portion, put the foot straight because we want a nice AP knee area. Make sense? So there's your 2 views, your proximal and your distal AP. Okay, well the 2 views of that view. Now the lateral femur, I'm gonna have you frog your leg out. So bend your knee up and then let your leg fall outward. Good. Scoot your whole self that way. There you go. And again, I'm gonna reopen the 17 top to bottom. Put the top of my image receptor or top of my light field at the ACES again. There we go. We can turn our image receptor to match the anatomy, just like that. And then bring your leg back a little more. There you go. Put my marker in that bottom area. That's your proximal lateral, okay? Now for the distal lateral, we want a better lateral knee, right? So I'm gonna have her kind of twist her hips over this way. We can have her cross her leg over if we want to, like we did for the lateral knee. However is going to get the best lateral for your patient. Go right about there. Scooch back a little more. Good. Rotate your hips up a little more too. Get that to be better. There you go. So now our knee is nice and lateral. We're centered good. I have light field past the bend of the knee, so I don't have all the femur. And then I'm gonna move my marker just to the back side right there, but it's still in the same line. Okay, so there's the distal and lateral. Those are your two views of the femur. You have the AP upper and lower, and the lateral upper and lower. Questions about those? No? All right. Moving on. So now let's move on to the pelvis, because I already have my big image receptor, but we have to change our orientation. So for any pelvis view, it's going to be crosswise in the image or in the bucky, because my pelvis is wide, not long, right? So it's all about the anatomy as to how and why we orientate our cassettes. So crosswise, 14 top to bottom. I'm really struggling with this thing. There. Okay, let me come back up this way. I'm having to lay flat on your back. Okay. Crosswise now for any pelvis or hip, we can put our marker on the bottom right corner of the image receptor. Okay, this works out good because when our light field is on our patient, we may not have a blank light field spot to put it on our patient or on the table, but if it's in this bottom right corner, what it might end up will be in soft tissue. It's not going to end up superimposing over bone. Okay, so it's right there, and then I'm going to open my collimation 14 top to bottom, 17 side to side. Now we're going to have to fold this up a little more. Our centering is going to be 2 inches below the ACES. So we're going to find the ACES, go 2 inches below, and then to the midline. Okay, so in the middle of the ACES, 2 inches below. We should have light field, if I find her crest, we should have light field about 1 inch above that. So you want the top of your image receptor to be 1 inch to 1.5 inches above the crest, and then we're centering 2 inches below the ACES. Okay? She's gonna pigeon toe both of her feet. Good, just like that. Make sure when your patient pigeon toes that their whole leg actually rolls out. There you go, not just the toes together. Same breathing technique for all of these for this practicum is just gonna be hold your breath, okay? So this is our AP pelvis. It's also important that you come to the end of the table and make sure your patient is straight on the table. So that like their top half isn't over here. You want the pelvis to be straight. So make sure they're laying straight on the table. The other view for the pelvis, she's going to do a bilateral frog leg. So you're gonna bend both your knees up and let them fall out and touch the bottom of your feet together. There you go. Our centering now becomes 3 inches below the ACES. Some people, when they frog their legs out, it's gonna kind of scoot them up and you don't have to make any adjustment. For her, I just went down a hair more. The reason for this, we're not so worried about the iliac crest anymore. Now they're waiting to make sure they're evaluating those hip joints as much as they can. And so we wanna go a little bit lower. Make sense? So I didn't move my tube, it's still aligned, I still have my marker. The only thing I did was change her position and move her 1/2 inch to 1 inch. So AP and bilateral frog leg. Okay? Questions? No? All right. I want to show you guys the other 2 pelvis views, or 3 pelvis views that will not be on practicum. I'm going to show you guys the inlet and the outlet view. You can relax your legs. So inlet and outlet view are used to evaluate for trauma of the pelvis. As a student, I never did them anywhere except for UNM because they're the ones who get the super trauma patients. With this one, it doesn't matter what's happening with the feet because we're not evaluating the hip joints. So your patient can just relax their feet and legs however. Can bend the knees up if they want, whatever's most comfortable for them. For the outlet view, that's the one that has a range. So it's 20 to 35 degrees for males, 30 to 45 degrees for females. 30 degrees falls within both of those variables, so we can use 30 degrees for everybody, okay? I'm gonna come this way. If I'm angling 30 degrees, what is my SID?
Where we at, 40?
Yeah. 40 minus 6, so 34. So make sure your image receptor is lined up. As you can see, it becomes a really weird one with how steep our angle is, okay? So line up our image receptor. And then for the centering point here, we're supposed to be 2 inches inferior to the superior border of the pubic symphysis. So we know greater trochanter is in line with the superior border of pubic symphysis, so we go 2 inches below that, which is going to put us pretty much at the crotch. So where the legs and the groin come together is going to be where you center, okay? So if I have her turn her leg in and out, her greater, do it again. Her greater trochanter is right here. So I'm about 2 inches below that at the crotch, okay? With this one, we're seeing the obturator foramen nice and opened up. We're seeing the pubic symphysis nice and elongated, especially for females, the ours are kind of tipped forward. This is a good view to be able to look for separation of that pubic symphysis or for fracture of those obturator foramen.
Is there, with like leg positioning, because I noticed her legs are separated, like do you want them, how do you want them, is that?
It doesn't matter.
How do they lay normally? Naturally?
Yeah, that's fine, because like I said, we're not evaluating the actual femurs or the hip.
Sure.
We're looking at the pelvis itself this time. So I mean, obviously you don't want them all like wonky with a leg way over here or something, but just a natural position is fine. So this is the outlet. The inlet view is 40 degrees toward the toes. So we go 40 degrees this way. Now I need to drop 2 more inches, right? So we're gonna come down to 32. If I can push the right button, that'd be great. 32 to the image receptor. So come back up this way. Line up. Don't forget to line up on these. That's probably what I personally struggle with the most, is I'll get my patient all set up, do everything, and then I go take a picture and it's a blank picture because I didn't line up my button. So line up your button. The centering for this one is midway between the aces. So I find that bony bump, that aces, and then go to the midline on her. Something important to note here, because of our angle, this line kind of makes a little rainbow curve. So make sure that you're putting the middle in line with the aces and not this. If I put my side line in line with it, I'm way more up. Does that make sense? So make sure that that center portion is in line with the aces. So this would be the inlet. The inlet views the brim of the pelvis. It views that pelvic ring. Okay, this shows us that there's fractures on any portion in that ring. It also elongates and widens the crust or the iliac wings so that you can see for fracture there. And the way I remember the difference is girls always want the bigger ring, so the bigger angle is what we view the ring with, okay? So inlet is 40 degrees. Huh? Okay. We'll take the angle off now. The last one I'm going to talk about for pelvis is going to be the Judet method. Now, in our book, it shows the Judet method as a unilateral side. It shows that if you rotate your patient 45 degrees, the side up is going to show that iliac crest stacked, and the side down is going to be an elongated wing, or an elongated ilium. Okay, the way that I have always done them and always seen them done is doing it bilateral. So that's how I'm going to show you guys to do it. It won't be on practicum, but I'm gonna show you guys bilateral. Because really, what would be the point of not doing bilateral? You're getting information on both sides of the pelvis from one view. Okay, and then you rotate them the other way to get the other view. So for this first view, I'm gonna have Sydney roll halfway toward you guys. I'm gonna put this sponge behind her, go ahead and roll back. And you can hold this here if you feel like it's gonna slip out. Like the hospital, the sponges are usually like a slick surface so we can clean them better. So having them hold it there is a good idea. For our centering, I'm gonna line this up. Right there. So for our centering for this one, we're gonna find the ACES, we're gonna stay in line with the ACES, and come not quite midline because of the angle. We're gonna come until we see light field skimming here and light field skimming here, so we're seeing the whole pelvis. Does that make sense? It's not really exact, but it's gonna be in line with the ACES, about halfway between the ACES and midline, I guess I would say. Okay? A trick that I like to use is I like to tell my patient, if they're coherent, to pay attention to how rotated you feel, because we need you to have the same rotation on the other side. So they can kind of note how far they're rotated up. We can take the sponge out. I'm gonna take this out and let you roll down. Then when we come to the other side, she can kind of help me make sure that we do the same rotation on the other side. So go ahead and roll the other way for me. Put that under, go ahead and roll back. Does that feel about the same?
It's a little bit higher right here.
Higher?
Yeah, right there.
Okay. So see, that is helpful that your patient can be like, oh no, that doesn't feel quite right. It'll help you have less repeats, okay? So same thing, find her ACES, go this way a little bit, and that would be the other Jude method. So now, right now, we're seeing this right side of her stacked. So we're seeing that iliac wing on top of itself, and the left side's kind of widened and flattened out. If there's a fracture of the iliac wing, we're able to see displacement on this side that's up, and on the side that's down, we would be able to see like the like line that it's taking through the wing. Does that make sense? So basically right now we're doing a lateral of the right and an AP of the left, and then vice versa. Okay, I'm gonna take that from you and get a smaller image or stuff there, because we're going to move on to the hip. So like I said, the inlet outlet and Jude won't be on the practicum, but I think that those ones are kind of important to run through with you guys, because when I was still out in the x-ray world, students had a really hard time. Like I don't think that they had been shown them or something, and that this was a really hard time. So I like to at least explain what you guys should be seeing so you can have an idea. Alright, so small cassette for a hip. 12 top to bottom, 10 side to side. We're looking at the long hip, not a wide hip, okay? So lengthwise, same thing with the marker. It can just go in that lower right corner. I'm going to set my collimation to 12 top to bottom and 10 side to side. All right, the centering for this one, we're going to find our ACES, go 1 to 2 inches in, 3 to 4 inches down, right about there. And I'm gonna have her pigeon toe both feet. You really only need the right one done, but if they put their toes together, it helps keep them stable, okay? So again, 1 to 2 in, 3 to 4 down, and make sure we're lined up. And that is our AP hip. Again, that centering point is gonna be kind of in the crease between the leg and the groin. You also can have her turn her leg in and out, find that greater trochanter, know that that's in line with the pubic symphysis, come from the ACES, find the spot in the middle, okay? So that's AP. The lateral, she would bend her leg up and then out like a frog leg, put the bottom of the foot against her other leg. It's the same centering, but you're gonna have to kind of adjust because she flopped her leg out. So we're gonna go 1 to 2 in, 3 to 4 down, raising her like there. And we can turn our collimator head to match the anatomy. So that's the frog leg. So really, if you notice, all of these positions of our patient are pretty similar, right? The femur, the pelvis, and the hip are all pretty much the same position of our patient, just a little bit different centering. So, not too terrible. All right, that's it. Let me get you lots